Welcome to Alzheimer's Speaks Radio. I'm your host, Lori LeBay, and I'm so excited that you're joining us today. We are going to have a fascinating conversation as usual as we learn from people all around the world at all ages and stages of life. Stay tuned as we shift our dementia care from crisis to comfort.
Here we go. What you think about, you will bring about dementia change. We will.
Well, Dr. Chodos, I am so excited to have you on the show. It sounds like you are a real mover and shaker in the industry. You're doing a lot of cool stuff, being a geriatrician and the executive director of Dementia Care Aware, which I can't wait to hear more about that. So if you don't mind introducing yourself to our audience, that would be fantastic.
Thank you so much. It's absolutely a delight to be here. And yeah, so thank you for calling me a mover and a shaker. I really focus on educating and trying to reach our healthcare providers with tools and skills and education and materials and what they need to do more around early detection and supporting people living with dementia and caregivers. So that's really my focus. I am trained as a doctor. That's what I do. Half of the week is I do clinical care in the outpatient setting, mostly dementia. So I do see folks for just general geriatrics issues. That's my background, but ended up focusing on dementia because as a consultant, specialist, colleague, I was learning through the referrals and through the questions that my colleagues were asking me that dementia was really challenging, that they didn't have the confidence or the skills or the time, frankly, to diagnose, manage, support people living with dementia and connecting them to all the resources and all those things. So I just sort of like, my practice sort of creeped into that direction because it was what was really needed. And then I think because I was doing so much in that area clinically, it was just really, I had a lot of practical knowledge, on the ground knowledge. I ended up being in a good position to work for the state of California on this program. I work at UCSF, University of California, San Francisco. That's my employer and my job. But our academic provide physicians, we're academic doctors. So I'm able to apply for grants and things like that. And so this was a program that the Medi-Cal program, or like California's Medicaid, was working on to improve screening in their population, the folks that they serve. And so I was in that, in a good position to apply for it. And also because geriatrics is small, I don't know about your listeners, they may have found it's very challenging to find a geriatrics doctor. We are really small, so we kind of know each other, and I was able to really rally folks to work with me on this project. So we really were able to, at least out of the gate, have a statewide program in California. Now we're kind of in phase 2, and we're working on trying to reach healthcare all over the country. Again, really focused on that primary care kind of frontline workforce with Dementia Care Aware and learning how to screen, learning how to diagnose, learning how to care for people living with dementia. So that is my passion. It is what I spend most of my time doing. And I feel really, really grateful that there is and was and will be a career in this.
I appreciate so much what you do. And you mentioned, geriatricians kind of being a small group. Can you define what a geriatrician is? Because it's so dang small. A lot of people don't even know that you exist or what the heck you do.
Yeah, thanks for that. It's so true. And I will just say, how a lot of people say, I represent my own views, not that of my university. I don't know that everybody would, even in geriatrics, would agree with me with what I'm going to say. But really, I think, consider ourselves, many of us are primary care. So many of us will be in a primary care role or a primary doctor role in like a skilled nursing facility or something like that. So we're not necessarily always operating as quote unquote specialists so we do really come to patients and families or whatever someone's support system is with like a holistic approach to the person so that it's a good fit with primary care. However, we're kind of really where we excel is when folks are experiencing syndromes that are most tightly associated with aging, and particularly when they start to have functional decline and need support from other folks to get through a day. So we sort of, I would say the back of the rule of thumb would be if someone starts to have functional decline, that's a good indication that a geriatrician would probably be helpful. But really, we're sort of masters in these areas of complexity and syndromes with aging, and help people really get their care aligned with their goals and figure out kind of what are the most important things that we should be focusing on and managing, instead of just throwing every guideline and every sort of, well, we have to do it this way because this is what we're supposed to do for your heart. This is what we're supposed to do for your kidney. This is what we're supposed to do for this. So we're masters of frailty, and we say we're all about the F word, function. So that's kind of what we're about. But there isn't an age cutoff. So that's something that I get asked a lot, like, okay, so should everybody over 65 have a geriatrician? The obvious answer is no, because there aren't enough. But also, age is, I think we all appreciate really nothing but a number, and it's a cutoff for Medicare and some benefits, but that's kind of why that number is such an anchor. So really, when people start to have functional impairment and complexity related to aging and frailty and things like that is when we're most useful. Do all of us want to see every older person? Probably, that we love this work and that's the population we love to work with. So if there was tons of us, I don't think that would be a bad approach either, but I think we're kind of trying to find where we can be most useful. And that is really with people who are starting to become more functionally impaired and frail. That was an incredibly long answer, but part of the reason was I think a lot of this isn't automatic. Like we don't always know what we're talking about when we talk about these syndromes and things like that.
Well, what I have found, and correct me if I'm wrong, but when I talk with geriatricians, one of the things that I like is kind of the compassion and empathy that they're wrapped with, understanding that everybody might want to be treated a little bit different depending on what their long-term goals are, and what their quality of life means to them. Would you say that's a correct assessment?
Yes, I think we're trained to be very aware that each older person really is an individual and they're a different constellation of things going on. So there's no one approach. You really have to get to know the person, and you really need to understand their social context and more than just their medical conditions. On the other hand, I think sometimes we are really skilled as well at just understanding what the pillars or the basics are of what is increasingly called like age-friendly healthcare or age-friendly health systems. And so those things, maybe there are some sort of guideline type approaches, but that really is more on the systems level. Like we need to know that all older adults are screened for falls. We need to know that all older adults have, goals documented and advanced care planning done. So it's just these sort of general guidelines. But when it comes to your patient, we're definitely there to figure out what's important to this person and then how am I going to help them get there with all the things we know that are going on.
Okay, great. Now, one of the questions I ask all my guests is, have they been personally touched by dementia in their own family or circle of friends? Do you mind sharing with us your answer on that?
Yes, I have never been a direct caregiver for somebody living with dementia. And I'm always really open about that with patients because I want them to know where I'm coming from so they can decide how useful they think my advice is going to be. But obviously, I have a lot of day-to-day experience. So like 2 to 3 days a week, I'm working with people living with dementia as patients, of course. But in my family, so when I was a little girl, my grandfather, I didn't live nearby. They lived in Canada, which wasn't that far away, but not next door. So we saw him a few times a year. But my grandfather, who was this, human teddy bear of a person, just like Mr. Big Hugs, Mr. Big Sloppy Kisses, always really super into the grandkids, just Mr. Family Man, just the sweetest guy. Um, you know, he was the one who was sort of first affected in my family and had vascular dementia. and ultimately was needing a lot of care and moved into a skilled nursing near my grandmother. And then she would go there every day and see him. And I have some very key memories of him declining and just being a different person living with dementia, or like felt to me like a different person. But one of the memories that I hold really dear is he was having a birthday and we went to go see him. And I don't, of course, remember which one. I was probably 11 or something like that. And his caregiver at the nursing home brought him out, and I always say he was like, he like proudly presented him to us. Like he was like sparkling clean. He smelled great. He was in this nice outfit. He was at the time using a wheelchair at that point. And this caregiver was just clearly so caring and concerned and mindful about, how my grandfather was still a part of our family and how we would want to see him, and just so thoughtful. And I remember that and feeling like this incredible debt of gratitude to this caregiver for really just, clearly doing a good job and caring and being compassionate. And yeah, that memory really sticks with me, because I always think about how important it is for families to know that the person they care about is getting good care, and really cared for. And, even if that person themselves can't at this point get dressed or can't put themselves together, that doesn't mean that it's not still important to them, not still important to the family. And it just showed this level of care anyway. So I think about that memory a lot. That's probably my strongest memory. And now actually, as I'm getting older, I have some friends and spouses of friends who are being affected, and some of my mentors and things like that. So I'm seeing it and being a lot more involved at earlier stages.
Yeah, it's interesting for me. I remember my first touch with it was when I was like 13 with a great aunt, and I'm 66 now, so that was a long time ago. And I remember just being devastated the day she didn't know who I was, and how that stuck with me. And I remember saying, I don't ever want anyone to feel like this again, like that they've lost the connection and the love. And that's what I felt. And the only thing that I heard back from my family was, Lori, this is what happens when you get old.
Mm.
And that was it. And I just thought, wow, there's got to be more. And then it turns out my mom gets dementia, lives with it for 30 years. And that was totally life changing. And she's been gone for 10. And now I'm taking care of my helping with a neighbor, with a good friend, and actually with my ex-husband and his wife. And so people are like, gosh, you're just becoming this dementia draw. And I'm like, it's happening for a reason, to kind of retrain me that not much has changed. Even though a lot has changed, not much has really changed. And anyways, that's what I'm finding in the medical field. And so I love talking with people like you that are just really out there trying to make this change and get things implemented to make it easier for families to care and understand, and the processes and stuff. And so it's like I said, I'm excited to have this conversation with you today. So thanks for sharing that. Can you tell myself and our audience why you think it's really important for people to discuss cognitive health? People hear the word, dementia or memory loss, and there's just this big pushback. And I don't want anyone to know. I don't want my friends to know. I don't want my family to know. My gosh, I don't want to tell my doctor. But it is really important that we have these conversations and we remove this fear, I believe. So I'd love to hear why you feel it's important as well.
That is such a good question. And okay, there's a lot there. I think I actually I'm very sympathetic to that impulse to avoid, because I think it is really scary the way it kind of unfolds right now, right? Like, people know that if they disclose that, and if they're open about it, if they happen to know, then they do, people may start to avoid them. They may start to exclude them. They may not know how to interact with them. I mean, there's just so little general knowledge and general understanding and inclusion that I just totally understand why it would be terrifying and why people avoid it so much. I also think that there is just not enough out there yet, right? This is the kind of stuff we're working on, you and I and many of my colleagues, is how do we give people the tools to talk about this? How do we give them things to talk about and ways to talk about? I think both of those things need to be addressed, because it's kind of awkward to talk about. And then it's like, well, what are we even talking about? Because there's a lot of misconceptions. There's a lot of, like you said, is this just, you're getting older? I see a lot of infantilizing of older people, patronizing them. Nobody wants that, right? It's completely normal to find that really annoying and really distasteful.
At any age.
Totally at any age, and every time people are like, she doesn't want to go into a home or something, it's like who does? It's completely normal not to want to take that step. Like most people want to stay in their home. That's a far more comfortable setting. So I think we're also really need a lot of skills help catching up on what we're talking about and how we should be talking about it in a way that really preserves somebody's dignity, autonomy, respect, compassion, all of those things. We also have the problem that a lot of people don't actually have insight into what they're experiencing if they have dementia. And so that's an added, I think, layer that you kind of don't know sometimes if people are ignoring it or if they truly don't know. And, if they're in denial, as we were kind of talking about, or if they don't know. And so that's another area of skill that we need to build, is how do we support people, work with them, have compassion, act respectfully, allow them dignity, and maybe not ever get to a place where they have insight and can directly address it. Okay. But having said all that, and that I sort of really get that, and I think we don't want to run away from that or act like that's not happening, that all these fears aren't kind of justified and real for a reason, and that we should be addressing some of the underlying issues there. I think the reason that I feel so strongly we need to move to proactive conversations about brain health and, address cognitive health in general is because we are missing years and years and years of opportunity to make people feel better, do better, think better, be better. There is so much we could be doing, and we just miss these windows, and then we end up in all of these crisis-driven situations. And there is probably no future where people living with dementia who are going to get, have a lot of symptoms. It's going to interfere with life. Their health is going to decline because the body gets frailer as the brain gets frailer. All those things are absolutely going to happen. We are not really trying to minimize the crises around those when we don't take an early approach and give everybody the opportunity to prepare, to understand what's going on, and then to do what we call a dementia care, where we always refer to brain health plans. Like, you need to address the brain health aspects of the healthcare and the social care that are really, really easy, actually. So that's the other thing that I also find frustrating, is that all the brain health and proactive things we could be doing are actually quite easy. It's just that we're not recognizing when is the time to do them and how to do them.
Yeah, well, and I think for me, part of the problem, and I know not everyone will agree with me on this, but for years and years and years, I believe this disease has been promoted by fear to get money for research. And I don't think we have to scare people. I think we have to give them hope, and we have to support them. We have to shift from fixing them to supporting them. And one of the things that I did that you just might find of interest is I wrote a children's book called Betty the Bald Chicken. And I always thought it was dementia related. And I've done it as a keynote for years and years and years. And I didn't get it published until around COVID time, right after COVID. And what I realized, and I'm so glad we waited, was it's really a book about how do you want to be cared for? And how do we have that conversation? How do we start with little kids about how they feel, how they care for others, and how they want to be cared for? Because, caring for one another is a broad band that we do throughout life, to people we know, to strangers. We make choices all the time, but we're not acknowledging our impact on one another. And I think we have to start with, instead of, so often we drill down and it's like, okay, we have to have this conversation because you have dementia. No, we should be having this conversation because you're a human being, and looking at those things. And then I think too, our word choices, even like today, for example, the ambulance came because we had an issue with insulin. Okay, and I went outside and I said, this person has dementia, but please don't use that word, because she doesn't acknowledge herself as having dementia. So of course we're in and they're like, okay, you've got dementia. And it's like, you can use other words. You can say, oh, I heard you had a little mix up with your medications today. And let's get to I mean, there's just other soft words that we don't have to make people feel that all they are is the diagnosis. And that's a real simple thing to change, but it's getting out of our heads and into our hearts. And I think that's one of the biggest, toughest things for people to do, because we've gotten so task oriented with so many things. So but getting that conversation started, and I think it's hard to, I'll just talk from the other side of the plate of, we go in for these screenings and everyone's scared they're going to fail the test, and or go in for like the 3 or 4 hour psych test, social psych tests and stuff. And I hear from doctors all the time, oh, it's not a pass fail. Well, you know what? You can tell yourself all day long, it's not a pass fail, but that is not how the patient feels. They know if they're doing well or not doing well, and they know consciously or unconsciously what that means, if they're having a conversation or not. And I think we have to dig deeper on that level in terms of how we look at some of those things. And I don't know if you would agree with that or not, but like I am struggling right now, and I'll use this as an example, and I'd love to hear your thoughts of, we need to get somebody diagnosed, but I really don't want to put them through that, because I know how traumatic and difficult it's going to be, because they will know. And this is something they don't want to have, they don't want to have to deal with, and it's going to be slapped in their face. And I think it's going to make things terribly worse. And yet, we can't get things like, the guide supports and things that we want without that diagnosis. And I'm just thinking, it's very obvious what's going on here. Why can't we do this in a different fashion? I mean, it's so extremely obvious.
Right. Okay. Lots there. And I do really agree with you. I really like that expression, getting out of our heads and into our hearts. I mean, on the medical side, we have to do both, which is we have to like reinforce the clinical practice elements of good care for dementia. And we have to, like you said, allow for some compassionate approaches that allow the person to get care without hinging on certain things, like you have to accept that you have the diagnosis or whatever it is. And I think as you were talking, it made me think of a couple of care models. And the analogies only hold for so long, but one that we talk about a lot, especially with the early detection efforts, is cancer, right? Most people understand you want to catch cancer early because you can do more. In some cases you can cure, but kind of regardless, you can, and we can't cure dementia right now, any of the types, but we know there's just so much more we could do, and the person would be doing better, for longer if we addressed it earlier. So that's one analogy. And I think it also kind of holds that some people would be so scared, I have this lump. There is no way, like, I'm just going to ignore it. That's a better strategy for me. Some people will always be that person, but I think giving more people a sense of there actually is really meaningful, excellent care waiting for you, I think that would make it a lot less scary for many, many people. It would allow, a moment of, okay, it's still scary, but I can embark on getting care and engaging with healthcare on this condition. The analogy where that starts to break down, though, although it's not always true, because a lot of older people get cancer and some of them have dementia. But for dementia, there's just that, again, that group, which is the kind of the person you're talking about, who doesn't have insight or can't go there, and can't I'm actually always really, I'll be honest, proud of patients that sort of say, there's no way I'm going to let you do this test. You're going to label me as crazy or something's wrong with me, and you're going to take away my, you're going to interfere with my bank accounts or whatever they're worried about.
Yep.
And they're not always totally wrong, right? And I'm like, this is a good protective instinct. I'm actually really proud of you for protecting yourself. However, in the background, I'm thinking this is actually a sign that something's probably really going on. And like you said, often it's so obvious, but because they won't submit to some sort of official evaluation, we won't label it. I think that's unnecessary. I mean, we're really trying to diagnose a clinical syndrome, which, like you said, can be incredibly clinically apparent. You often don't need any sort of additional testing. You may want to do some basic blood work, try to get a brain scan, but you don't have to do the paper and pen testing. That paper and pen testing isn't necessary for anybody, even if they're willing to submit to it. It really has to do with the clinical scenario. So there are a lot of ways around it and ways to identify people and give them the right care, even if we're never having the full conversation with the person because they're kind of blocking it. Now, the thing we have to address, especially with healthcare, is the ethical challenges that presents for the healthcare providers, which is we usually feel like, well, no, we're making decisions with a patient. So they have to understand their diagnosis because that's really the basis for all of our care. That just breaks down with dementia because of the fact that the actual organ being affected is the brain and the cognitive functions. So we have to, if we are really going to treat people with dementia compassionately, completely, with excellence, we have to have a strategy for those folks that will not get an evaluation or do not understand that they have the diagnosis and won't let us label them that way. And that has to be okay because it's actually part of the condition. So I really do agree with you there that there's some countercurrent issues with dementia, with the way our health system works right now, with our medical ethics, with the way we sort of allow ourselves to partner with patients and families on care. But we should be working on how to get around those so that we're actually caring for people. Because the only other option, if we can't address that, is to leave people hanging. And that's unacceptable, in my view.
Well, and I think some people feel left hanging even after they get a diagnosis because there's not a cure and there's very little available that most doctors know about, in terms of social connections and social prescribing. I mean, there's so much help and resources that are free or low cost, but they're not getting that from their doctor and they're expecting that from their doctor. So I think that that's a huge connection that has to be changed. That's one of the reasons I started Dementia Map, was to try to, make those connections easier and more accessible. And it's not that I really don't even think families expect the doctors to do all the research, but just point me in the right direction. Because depending on where the person is at, if they are early onset or maybe mild cognitive impairment, whatever, 99% of the time, they're the ones doing the research because they have the time because their spouse is still working, And then, you get the younger kids in the family that they love hopping on the computer and seeing what's out there on the internet. And it really can empower the families to be able to do that. So I think that's part of to me, the missing factor too is, okay, now I have it. And I hear this from families all the time. Now, what are you doing for me? All you're doing is having me come back in for another appointment and another scan, but that's not helping me with my day-to-day life. And that's, that's to me is part of the pushback and things. But again, I think we're never going to change it if we don't get both sides talking, and having this conversation to find out what the true needs are. And that's why it is critically important. And it will make a difference in terms of, not just a dementia diagnosis, but all of your health care, to make sure that it's coordinated. Or how are you communicated with? And I see this a lot too, and it can be really simple stuff. If they're calling the person with dementia to remind them of their appointment, well, that's not going to work. And so we've got to pull other resources in to support them. And I think the geriatrician aspect typically does that easier. But I don't really see a lot of clinics with necessarily social workers or ecosystems to be able to support those things, or even support groups where people could go, or informational groups where they could go. So it's not laid on the doctor, but it's part of the clinic or the practice, to support those things. Because I think, to me, that would be more welcoming and greatly appreciated by everyone, in that fashion. Do you have, some guidelines in terms of, if a family has concerns, how to bring this up? Because that's the other thing. You got HIPAA, and it's like, I really can't talk to the kids. And I know I had that with my mom, and the nurse said, I can't talk to you. I said, listen, sweet pea, I'm not asking you to talk to me. I'm not asking you to give me any information, but I know HIPAA too, and you need to listen to me, and you need to get this information to the doctor. And because we had a major issue, and then they went back and talked to my mom and said our whole family thought she had Alzheimer's, and we weren't the ones saying that. It was my mom that was saying that. We were like, did you have a stroke? What's going? I mean, we had no idea back then, and it was a horrible situation. I know it's gotten better, but I don't think people know that they can reach out to pass information along, to a doctor. And maybe I'm wrong on that, but back in the day, I'm like, this is what's going on. I'm calling on this person's behalf. And again, you don't have to give me any personal information, but when you meet with them, you need to take these things into consideration when you're meeting with them, because, so many of them can put up a good front and everything looks great for that 10-15 minute meeting. And yet there's all these other things going on. And that makes it really complicated, I think, too.
I think you hit on a really important issue that we talk about a lot. And this is what I would give direct advice about if someone was concerned and trying to figure out how to help somebody that they didn't think it clearly wasn't getting to the attention of the clinician. I do say, yeah, that clinician, may not know to reach out to you, or, your mom said, please don't call my children. I always say you can always leave them a message and tell them what you need to tell them. So you're correct about that. That is not them sharing information with you. So you can always proactively share information. The other thing is, again, and the last couple scenarios you were describing before you asked this question, the thing that kept coming to my mind was how dementia unaware our whole system is, right? Everything is set up as if people don't have dementia, despite the fact that it's an incredibly prevalent condition and older adults are getting much more healthcare than younger adults and all those things, right? So totally agree with you that a lot of things make no sense, and it's because we act like dementia doesn't exist and we are not sensitive to it or proactive about it. But and that includes the basic things of all basic mechanisms of healthcare. But if I'm a clinician and I'm assessing somebody, and this is what we teach, I was just teaching residents yesterday from family medicine, and this is what we teach in dementia care, where collateral it's just a part of what you need to get. And if you can't get it because the person is saying no, you can't talk to them. I think we all have a different threshold as clinicians about how we feel about reaching out regardless. So if I'm really worried about somebody, so if somebody appears to be doing well, like let's say all their health conditions are well controlled, they don't appear to have any signs of self-neglect, they, everything's okay. I'm just noticing something's a little off when we're having a conversation, or I do a test and they don't do well, and I'm, proceeding with some assessment. And I do really feel like, okay, now I need some collateral information. If they're fine, then I might say, okay, I'm just going to keep working on this, and I'm going to see them more often to sort of build that rapport and try to make them comfortable and explain to them why I want the collateral information, or talk to somebody who knows them. On the other hand, if I'm worried about them, I kind of have two options. And one is reach out anyway and say, I'm your mom's doctor. I can't really tell you anything about that's going on with her, but just wanted to see if there's anything you feel like I should know. And there is like a HIPAA thing. There's an ethical line there that, people feel differently about crossing, but there is literally no way to take care of people with dementia if you cannot get collateral in certain scenarios. And it just isn't even safe. It's not appropriate. It's not practical. And the question is, you should always, like, if let's say you're seeing a lot of folks with dementia, you might want to talk to your practice manager, your medical director, whatever it is, and get on the same page about what is our policy with these patients so that we all feel like we're covered if you're feeling like the legal aspects of it are a problem. But generally speaking, that's really well received. It's really helpful. It's all for the better of the patient. But I think the other option, if you really, that's not something you're going to do, is just call somebody and say, I just want to give you the opportunity to let me know if anything's going on. I'm not going to say anything about your mom. If you feel like even that is too much for you, I just call Adult Protective Services, because at the end of the day, which sometimes, are variously empowered, resourced, and skilled in different places across the country, but it is our obligation, if we worry about self-neglect in any way, to report. We don't have to prove that, we are mandated reporters for any suspicion of abuse, and abuse includes self-neglect. And so if I cannot get more information and I need this person to be checked on, I'm going to let them know that a social worker from the community and from this resource is going to meet them. And I would just like to know that, we have other resources for them and that we're making sure everything's going well at home. So I often feel obligated to do that if I can't get any information and I feel like there's no real way to reach out. The other thing is I have a lot of folks who have nobody, like about a third of my patients at least have no real meaningful social support. And, but they live in an apartment building. So I will try to, or they have a case manager. So I will try to get that kind of collateral and start building a network that way. But it is something that, like, at every point during our conversation today, we've like had to acknowledge that the gap is still really, really large between like what people with dementia should be getting and how they should be experiencing healthcare and connections from healthcare to social services and where we are today, right? It's really, we have a lot of work to do to make a dementia capable system.
Yeah, I really wish that we would get the healthcare directives implemented and talked about and addressed from the day people are 18 years old. It's the same with wills, because, when we're approaching it, when there's a chronic illness or someone's, elderly, right away, their mind goes to end of life. I don't want to deal with that. The roadblock is up. But this is really about smart living and smart care. And things have gotten so complicated. And one of the things that I really bring up to people in my support groups now is, listen, your doctor has a scribe. They either pull somebody in or they're recording, because it is so much information for them to take in. You can bring in a buddy to hear all this stuff, or a support person to keep on track, because your health is complicated. If it's medication changes or appointments or whatever it is. And I think that approach, what I have heard is people are receiving that much better, because now it's not just because they can't handle the information flow. It's, the doctors are almost establishing that and saying, is this okay that I use this thing? And maybe it's that they record to bring it home or whatever, depending on what stage they're in. But have, and we've talked about that for years, the second set of eyes and ears are always helpful, because we hear things differently, and we can be more thorough and get more questions and answers done in a short period of time when we work as a team. And so I think starting that at a younger age is would be smart, a smart approach. And again, then it makes us more all alike instead of different, which is part of that fear factor. Let's talk about, key things that people can maybe modify in their life to reduce the risk of dementia that patients and doctors both need to be aware of.
Absolutely. Lori, can I address the advanced care planning issue real quick, though?
Oh, sure.
So I agree with you. And also, I think one problem is we're thinking of it as one thing for everybody, and not like it should be age and stage appropriate, however you want to think about that. So what I always emphasize is the most important thing is of course, I hope this doesn't happen. I don't think it will, but like, let's say you get a severe case of the flu tomorrow and you
Yeah.
need intensive care. Who is your advocate? Who's your surrogate? We need to have that kind of stuff established,
Yeah.
like tomorrow. And I'm not, overly urgent about it, but I think we could take a triage approach because let me tell you, human beings need context to make decisions. And I think this is one of the areas where I've been taught by some of the experts I work with, we kind of go wrong when we try to do advanced care planning the way we do it with like, do you want dialysis? Do you want a machine? And what everybody will say is, I don't want to be a vegetable. Don't, unplug me. And that is so often no one's even talking about that. That's not even a realistic thing. Yes, some people end up in very intensive and complicated scenarios at the end of life, but usually that's in the context of now I've had, kidney disease for however many years, I've been on dialysis for however long, and people are unfortunately, very ableist, and they really discount the quality of life with a chronic illness or a disability. And yet when we talk to people with chronic illness or disability, they report good quality of life and they've adapted. So we don't focus enough on how resilient and adaptable human beings are and focus more on, boy, it sure must be terrible to have a chronic illness. I wouldn't want to live that way. Unplug me. I had a relative who used to say to me all the time, if I get like that, unplug me. And I was like, well, get like what? And you're not plugged in. So what do you mean? And it was just a way of saying like, we have these sort of shorthands for things that actually end up being really specific contextualized decisions, and people have very, very different feelings about them when they're in those situations. So what I always emphasize is we should be triaging this. Like, everybody needs surrogates and durable powers of attorney, designated in the case of emergency. And then if we have a chronic illness, we should maybe be circling back and documenting how we're feeling about our care plan there. Is there something we would or wouldn't want? And then when people get very frail, of course, I think it is actually more appropriate to really dig in on, all right, what are the goals now? And is this kind of scenario, which is, if your heart stopped or you stopped breathing in the community, that you would not want to be resuscitated and allow natural death in that setting. So I do caution that I totally agree. And it's like taxes. It's like getting your license and registration. Like, they're just things you need to do. And for some reason, we don't do this thing of designating another adult decision maker in the case of incapacity. But on the other hand, I don't think everybody needs a full advance directive if they don't need it, I guess is what I'm saying. And that could be a more personalized, sort of customized thing. So that's how I approach it clinically, because also I feel like I get a very little juice for the squeeze if I ask somebody who's really pretty well to give me an advance directive. They're sort of like, well, sure, I guess I want dialysis, or they lean on sort of those tropes that you see in movies of like, no, I don't want to be the person who's a vegetable, whatever that means. I don't know if you would agree with that.
Yeah, no, and I also have found the approach of doing it as a group or a team, so someone doesn't feel like I'm sick, so I have to do this. So I just did this with a person with dementia, and I remember the husband going, "Oh, there's no way she's going to get through this." We had the most fascinating conversation, and he was just shocked because she had some definite thoughts about how she wanted to live her life, and giving that opportunity and talking about it, not judging, and then saying, Tom hopped in and said, yeah, this is what I chose, and I said, this is what I chose, and now it's a conversation versus a hard stop to do. And it was really learning and informative, to know that about one another, because those are such personal, intimate things to know. And so that switches it, I think, on its head as well.
What a great suggestion. I'll just say, what a great suggestion. Yeah, that sounds like really the ideal way to do it.
It just takes the scary out of it. We did that with my folks with, getting their will and all of that stuff done. And my dad, we don't have that much, blah, 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 blah. And I just said, how about if Tom and I go in and we're going to do ours at the same time? And then it just, we both had questions for one another in the process, and with the attorney and stuff. And it was just easier, and it didn't feel as heavy, I guess, to do.
Yeah,
and it just felt more like it was about really living with control in your life, and and preserving that right to make decisions no matter where you're at with things. But let's get back to if you want to bring a couple of things up about how people can maybe prevent dementia, or I mean there's no true prevention, I should say reduce their risk
Yeah,
of getting dementia.
absolutely. And thank you. And the really wonderful thing about this is it's like kind of a package deal of things that are, again, not very dementia focused. So you don't have to, as a clinician, I don't have to focus on I'm preventing dementia or I'm treating dementia here, if that again is a touchy subject. So
Mhm.
there's so many seemingly non-specific things for the brain that we can do that are going to really reduce risk. And they're kind of all the same things to reduce the
Mhm.
speed of progression if you do have dementia. So it's a
Mhm.
double, you get sort of two bangs for your buck there, which is if you really get good at what we call brain health care, then you really help prevent and help slow anything that's going on. And if you have somebody like you were saying that just you can't get the diagnosis or they won't let you, you could still implement this and be doing basically all the things you need to do anyway. But the big ones are um, one of the biggest risk factors in midlife is depression. So being
Mhm.
sure to do mental health care and addressing depression. But the two really big ones are high cholesterol, particularly LDL, so treating that,
Mhm.
and hearing loss. And this is I go on and on and on
Mhm.
until I'm blue in the face about addressing, like diagnosing and treating hearing loss. That has its own issues with stigma and inconvenience and expense that really are barriers. But to the extent that we can try, we need to support people. The other risk factors that we address are social stimulation and isolation and loneliness, so more social activity, and then physical activity. So the brain and the body are connected, very much so. And so it appears that physical activity is really, really good for the brain. So we try to increase social and physical activity. Reducing alcohols, it does appear, unfortunately, that moderate and heavy alcohol use really do worsen cognition. I think that's kind of obvious in the short term, but it looks
Mhm.
like in the long term, it really increases risk as well. And vision loss as well. So vision and hearing, we try to address as a package, but vision loss, usually people are very proactive about that
Mhm.
or they're addressing it. So um, there are other things like air pollution, which obviously we can't really always address out of the gate as clinicians. Um, but anticholinergic medications. So the more we're on those in midlife, and so in late life, it's less of a risk for developing dementia, but it makes cognition a lot worse. And the
Mhm.
thing about anticholinergic medications is a lot of medications have this, what we call property of being anticholinergic without being labeled as that class of drugs. That class of drugs is often things like bladder medications that we'll take for urinary, like overactive bladder, things like that, or muscle relaxants. But in clinic, we do something called an anticholinergic burden scale, and we actually like put in everybody's medications and see how much anticholinergic burden they have because so many medications have a little bit of that activity. And so we try to get those medications off, substitute them for other things. Unfortunately, the same is true, sort of like alcohol and anticholinergic medications is true for what we call benzodiazepines and other sedatives and antipsychotics. So we have to look out for those too. Benzodiazepines are things like sleeping medicines and relaxing medicines. So Valium, Ativan, or lorazepam, clonazepam, or Klonopin. So we really aggressively recommend getting off of those. So the big ones, the brain health plan really is treating the physical and social activity, hearing, vision, any medications that are a problem, making sure to get those off, and treating the cholesterol. There's a little bit of a package there too with other what we call vascular risk factors. So making sure diabetes and high blood pressure are relatively well controlled. It doesn't have to be, pristine perfect, but
Mhm.
just relatively well controlled. Because sometimes if we aggressively treat those people actually feel worse or do worse when they're older. So we want to
Mhm.
be, we balance that, but we don't want it to be like, raging out of control. That
Yeah.
really does take a toll on the brain. Those are the biggest ones and the ones that I think are very they're just right there. We can just really take care of those. And patients are certainly, we're all at this point really used to being advised to do more physical and social activity. And we know it's good for us. I think the things that are less obvious to people are the medicines, the hearing and vision, and then making sure that our other conditions are kind of optimized.
Yeah. And I guess I would add sleep and hydration in.
Oh, yeah.
Those two are, just have such a huge impact. And the older I get, I see those things affecting me. It's like, okay, I gotta drink more water. I'm getting a little loopy here, getting more tired, and yet I'm not really sleeping well and all of those types of things. So
Yeah, and the sleep is sometimes the thing we're usually looking for is sleep apnea. And the way we think it does cause like oxygen drops in the brain, which are really part of the problem. But what it really ends up doing is really sort of supercharging high blood pressure. You end up getting these spikes in high blood pressure. So that's the other thing, particularly in middle age and older age, we start looking for sleep apnea as a way to really addressing sleep apnea to really improve symptoms and probably reduce risk as well.
Oh, I've never heard those two tied together. So that something new I learned on that one. What are some ways that people can offer support to a loved one who is living with dementia?
Well, it sounds like they can listen to your podcast and get lots of advice. I think, one of the things that is probably really empowering, frankly, is to learn about dementia and how behavior and communication changes, because I see that as one of the bigger barriers for people in terms of continuing to engage and continuing to support people with dementia, is starting to accept and understand the ways that people are communicating differently and behaving differently, and understanding how just absolutely natural it is as part of the condition they're living with, instead of, like, I see a lot of upstream fighting against it because yes, that person's changing, which is obviously a huge adjustment for everybody around them. But then also some of the behaviors are strange, right? Or they're not sociable or not appropriate. And that is just something we all struggle with. But when we start to recontextualize it in, okay, this person's brain, excuse me, is structurally changing, and I'm seeing some of that here, but still emotionally we can relate at the same level, even if the words we're using or the content that we're talking about is very different. That person is still there as a person, and emotionally they're still responding, and emotionally we're still connecting. Just it's really us that have to change as they're changing as well. And so I think the more we can lean on all these incredible resources out there, Alzheimer's Association, all of these, local organizations in California, we have a ton that really focus on supporting us as caregivers and people around people with dementia to understand that and get some skills around how to work with people with dementia better. I think that's really important because we want to still see that person and be able to interact with them as a person, right? And that's super important.
Yeah, I think changing our verbiage to even from caregiver to care companion or care partner, because it puts us into relationship-based care. And, to answer the question about, how can we support our loved ones? One of the things I always recommend to people is be relationship-based. I got very task-oriented because I had all these things to do. And so I just focused on the task and I stopped focusing on how am I making the person feel. And it was like, well, that was kind of idiotic. And then I also realized, like, I shouldn't be using the word behavior. I would not want to be told over and over and over again, stop that behavior, don't do this, don't do that. And look at the whys, because all of those behaviors I have found are clues to something is off. And we do that with a small child. They can't talk to us, little baby. So we're interpreting the cues and the movements and all the things, the body functions and the sounds and the expressions. But we don't do that with our elders or people with dementia. And if we would slow down actually and do that throughout life and not lose track of that, we can read better what is actually happening. But we've gotten so reliant on just words, and words get mumbled and jumbled and lost, and so they don't always make sense. when it comes, to dementia. You have to listen at the tone and what are their eyes saying, and all of those types of things I think are very simple to do, but you have to slow down to do it. And then
Mhm.
it's like, oh, well, that's avoidable. I didn't realize sound was an issue. I didn't realize lighting, was going to have, you're seeing these patterns of triggers that are all controllable things and avoidable things in many, many cases with that. So, in wrapping up, how can doctors improve elder care for themselves and their patients?
I'm probably going to stick with a dementia recommendation here. I think investing a little bit of time, and of course, like our program, Dementia Careware, is like has all the tools, but if that's helpful, but investing a little bit of time in deciding, how you're going to do better around dementia. Half of people die without ever having received a diagnosis.
Yeah.
And I can't think of another condition where we're doing that poorly. It just seems really like a big miss. And
Mhm.
so finding ways to incorporate elements of detecting it a little earlier, diagnosing it comfortably, supporting people with it, or, establishing brain health care plans for folks. All of these things will improve care.
Mhm.
And we got to start somewhere. We have all these areas of work to do, and we're not going to get them all done, but just starting to really, I keep thinking most of us are living in cities, counties, communities that aren't aging. They're aged. Like we have a much higher percentage of older adults than we ever did before. And this isn't a future problem. It's a now issue. And people are living their lives without knowing that they have this and very likely coming to avoidable harm. So I think we can do so much better. And a lot of this is very implementable tomorrow.
Mhm.
So I'm hoping people learn the importance of early detection, learn that patients and caregivers want that they want support, that we can't support them with brain health care and connecting to social services and helping people really truly, like the dream is that people are really living better with this condition, and it's really achievable. We just have to start implementing it.
Do you find it helpful? Because I always encourage families, if you find a resource, let your doctor know.
It was like 2 years later, somebody finally told me, "Yeah, you mentioned that last time," and I called them and they said they don't actually do this thing or whatever it is. I try to make an effort if I'm routinely referring to like connect with that organization, make sure I'm
Mhm.
referring in the right way. How do you want me to talk about your organization? How should I be, you know, who's the right client for you, that kind of thing.
Yep.
And but that takes time, and usually it's time I don't have. And it's because I don't have a dedicated social worker that I need to do that. But I absolutely. So that would be extremely helpful. Like, oh, thank you. You recommended us this free legal service. It turns out they won't help people with dementia because they don't know how or whatever it is.
Mhm.
So any advice you can give and anything that you've particularly benefited from, it's like that's absolute gold if you were to share it.
Well, in wrapping up, Dr. Chodos, I cannot thank you enough for your time today. This is just kind of blown by, but you've given us such great information and insights. Now, people can go to your website, dementiacareaware.org. You're also on LinkedIn and Facebook. So please reach out and spread the word. And like I always say, be a giver of hope. Like, click, and share. You don't know who in your sphere on social media or in person is in need of this information, because we aren't open enough as a society yet to have these conversations. And the more information people see, the more likely they'll feel comfortable reaching out when they're ready to. So thank you all so much. And again, Dr. Shados, thank you for all the work you're doing. You really are a change maker. So thank you.
Oh my God, right back at you. Thank you so much. This was so delightful. Thank you.
So, in closing, I just want to again encourage everyone to go check out alzheimersspeaks.com for all of our free educational resources, as well as our sister company, Dementia Map. Till next time, bye now.